Positioning Lesson 14 is Surgical and Mobile Radiography, the practical hands-on skills of working in the ICU, operating room, and trauma bay. 13 minutes covering mobile unit operation, sterile field rules, C-arm fluoroscopy, radiation protection, and the common ICU line placement landmarks every radiographer must know. Mobile units use two power types. Capacitor discharge, battery-powered, is the most common mobile unit. It stores an electrical charge and releases it for each exposure, producing consistent output regardless of wall power quality. High-frequency mobile units, superior output consistency and lower patient dose compared to older designs. Drive system, motorized steering, always push, never pull. The machine steers itself. The operator controls direction. Speed and maneuverability in tight ICU corridors requires practice. Portable digital detectors. Wireless flat panel DR plates are now common in ICU and/or environments. Images transmit to the workstation within seconds. SID must be measured and documented for every portable exam. It affects MOS calculation and D1 tracking. Exposure index monitoring is essential. Portable exams are prone to dose creep. Technique considération. Shorter SID than room exams, typically 40 to 48 inches. Document actual SID used. The heart appears larger on AP portable than on PA upright. Greater cardiac magnification because the heart is farther from the IR. The diaphragm rides higher in supine position, making lung bases appear denser. The sterile field rules are non-negotiable. Violating sterile technique is a patient safety event. Never reach over or across a sterile field. The drape barrier is the sterile boundary. Crossing it with any non-sterile item contaminates the field. If a sterile item contacts any non-sterile surface, is contaminated, treat it as non-sterile and remove it from the field. The image receptor must be covered with a sterile draping bag before entering the surgical field. The scrub technician handles placing the sterile covered IR in the operative field. Pass the bag to the scrub tech and let them open it. Never reach over the field. Never turn your back to a sterile field. Maintain at least 12 inches of distance from a sterile field edge. Surgical suite conduct. Lead apron under surgical gown, always. Mask and hair cover required when entering any operating room. Minimize traffic and movement during surgery. Communicate with the surgeon before placing equipment. Alert everyone before every exposure. Quote, X-ray, everyone clear, unquote. Remove equipment promptly after imaging. Document SID, KVP, MAS, and position for every surgical film. C-arm operation. The C-arm carries both the X-ray tube and the flat panel detector on a C-shaped gantry that can rotate around the patient without moving them. The surgeon watches the monitor in real time during the procedure. Tube position. Under-table tube is strongly preferred. When the tube is below the patient, scatter exits upward through the patient, away from the surgeon's hands and abdomen. Over-table tube directs scatter down toward the surgeon at waist and hand level. Higher dose to the operators. Radiation protection in the suite. Lead apron, 0.5 millimeter lead equivalent. Mandatory for every person in the room during fluoroscopy. Thyroid collar. Mandatory for fluoroscopy workers. The thyroid receives significant scatter dose without a collar. Leaded glasses. Recommended. Lens of eye is sensitive to radiation. Ceiling suspended lead acrylic shields protect the head and upper body. Under-table lead drapes block upward scatter. Two badge monitoring. Chest and waist badges for fluoroscopy workers. Pulse fluoroscopy at 7.5 frames per second reduces dose up to 75% compared to continuous mode at 30 frames per second. Last image hold, LIH, displays the last acquired frame on the monitor after the beam is off. The surgeon can plan, measure, and position using LIH without keeping the beam active. Use LIH aggressively. Every second of beam off time is dose saved. 5 standard surgical and ICU radiography applications. Intraoperative cholangiogram. During cholecystectomy. C-arm fluoroscopy. Water-soluble contrast injected through a catheter in the cystic duct. Demonstrates the common bile duct for stones before the duct is divided. Never barium in bile ducts. Hepatopalit. AP and lateral C-arm views during prosthesis placement. Component alignment and leg length assessment. Under-table tube. High KVP and MAS for metal penetration. Orthopedic fixation. Serial C-arm views during rod, nail, or plate placement. AP and lateral of the fracture site. True position confirmed before leaving the room. Portable chest in the ICU. AP semi-erect, 30 to 45 degrees if the patient cannot sit upright. SID, 40 to 48 inches, documented. Key line and tube landmarks. Central venous catheter tip, superior vena cava, junction. Endotracheal tube, 5 to 7 centimeters above the carina. Nasogastric tube, past the gastroesophageal junction, tip in the stomach. Portable AP abdomen. Supine AP. Post-operative ileus pattern is common. Document incident KVP. 70 to 80. Grid when the unit allows it. 3 surgical and mobile radiography questions. The answer is B. Stand at least 6 feet from the tube, behind the patient, wearing a lead apron. 6 feet is the minimum safe distance. At that distance, scatter is dramatically reduced by the inverse square law. Standing behind the patient positions the radiographer on the lower dose exit side of the beam. Lead apron is mandatory on all mobile and surgical radiography. Always. Alerting everyone in the room before every exposure is required. The answer is B. Cover the IR with a sterile draping bag before passing it to the scrub technician. The image receptor is a non-sterile item. It must be enclosed in a sterile bag before entering the surgical field. The scrub tech handles the sterile covered IR within the field. An uncovered IR passed directly into the field contaminates it, a patient safety event that can require redraping the entire operative field. The answer is B. Pulsed fluoroscopy at 7.5 frames per second combined with last image hold for positioning. Pulse mode at 7.5 fps reduces dose 75% versus continuous at 30 fps. LIH allows the surgeon to work from the held image without the beam on. Combined, these two techniques dramatically reduce or fluoroscopy dose. Under table 2 position also reduces scatter to the surgical team. Lesson 14 complete. Mobile unit types and technique. AP cardiac magnification versus PA chest. Mobile radiation protection including the 6-foot rule. Sterile field protocol. C-arm setup with under table 2 preference. Pulse fluoroscopy and LIH dose reduction. Commoner procedures and ICU line placement landmarks. CVC and SVC. ET 5 to 7 centimeters above carina.